Welcome back to the deep dive. If you just pause for a moment and really think about it, the human body's ability to heal itself is, well, it's maybe the most impressive ongoing construction project there is. Whether it's a simple scraped knee or a really complex surgical wound or even just the constant turnover happening inside our organs, the aim is always the same: getting that tissue structure and function back online, repair, healing, whatever you want to call it. We mostly take it for granted, don't we? You get a cut, you sort of expect it to fix itself. But anyone who's dealt with a wound that just wouldn't close, or maybe seen a really raised, tough scar form, knows this whole process can be pretty fragile. It's definitely not just flipping a switch and guaranteeing success. It's more like this incredibly complex symphony. Cellular events that have to happen just right, and they can be influenced, sped up, slowed down, or completely thrown off track by all sorts of things inside and outside the body. So our mission today is to kind of lay out the blueprint for you. We've dug through a whole stack of sources that map out the really critical levers, let's call them, that control healing. We want to bridge that gap between just general curiosity and some, specific clinical and cellular insights. We're really looking for those nuggets of information that explain why your body might heal perfectly one time, but then really struggle the next.
And it's important, I think, to define what we actually mean by healing here. Because the body has essentially two main goals when it's recovering, and sometimes they're competing. The best outcome, the ideal, is regeneration. That means putting back the original functional cells and the structure just as it was. But the fallback, the sort of default mechanism, is scarring. That's where the body lays down tough connective tissue, gives immediate strength, holds things together, but often, well, it comes at the cost of the original function. So the big question we're tackling today is what factors, both systemic, meaning your overall health, and local, like the conditions right there at the wound tip, that balance. We want to understand what pushes the body towards, say, too much scarring that limits function, or even worse, causes a total failure to heal, leading to things like chronic wounds.
Right. So we'll start by looking at those systemic roadblocks, things like nutrition, underlying diseases that affect the whole body's environment. Then we'll drill down into the local stuff, the challenges right at the site, like physical stress or foreign objects being stuck in there. And finally, we'll connect all those influences directly to the kinds of problems we see clinically, chronic ulcers or those really excessive deforming scars. Okay, let's get into it, starting with the body's internal environment. Okay, so when we talk about healing going well, we kind of have to start with when it goes wrong. And clinically, probably the single most common reason a wound just stalls out is contamination, infection. The second microbes get in, it's like the body's construction crew just drops their tools and has to pick up weapons instead.
That's exactly it. Infection is, clinically one of the most important causes of delayed healing. It basically locks the body into that first stage, the inflammatory stage. You see, the whole repair sequence is this carefully timed process. Inflammation first, then proliferation, where you build new tissue, and finally remodeling, where you refine it. But when pathogens, bacteria are present, the body has to divert huge amounts of energy and immune cells, especially neutrophils and macrophages, back into fighting the infection. And this sustained immune attack, well, it means a constant release of things like reactive oxygen species and enzymes that are meant to kill bacteria, which is necessary, of course, but it also causes a lot of collateral tissue injury.
So it damages the healthy tissue nearby, too.
Precisely. And that damage just feeds back into the inflammation, perpetuating the cycle. So instead of moving on to the proliferation stage, where fibroblasts should be laying down a stable matrix, the site just stays this destructive, unstable battlefield. It actively prevents repair and stabilization from happening.
Okay, so infection is maybe the most common immediate hurdle. But chronic systemic diseases, they pose maybe the biggest long-term threat, right? If we had to pick one disease that just fundamentally messes with almost every single stage of repair, it would have to be diabetes, wouldn't it?
Oh, absolutely. Our sources really highlight diabetes as a monumental challenge for wound healing. It's often described as a triple threat because it attacks the repair process from three angles that actually reinforce each other.
A triple threat, okay. What are the three parts?
So the first is circulatory. It's the underlying vascular disease. Chronic high blood sugar, hyperglycemia, directly damages the endothelial cells, the cells lining the blood vessels, especially the tiny capillaries. This process, it's called microangiopathy, makes the vessels stiff and narrow, and the result is widespread ischemia, basically, not enough blood flow.
Right.
And if you can't get enough oxygen, glucose, immune cells, all necessary supplies to the wound site, well, the proliferative phase just can't get going. The high energy demands of repair, making collagen, dividing cells, they just can't be met.
And the second threat you mentioned, neuropathy. That's the nerve damage aspect. That seems particularly nasty because it can make people sort of unaware of the injury itself.
That's a great way to put it, blindness to injury. Diabetic neuropathy is damage to the peripheral nerves,
Hmm.
and it means the patient loses that protective sensation of pain, pressure, even temperature. So imagine a tiny ulcer starting on the bottom of your foot because maybe you stepped on a small stone inside your shoe.
Mm.
A healthy person feels that immediately, shifts their weight, takes the shoe off.
Of course.
But someone with advanced neuropathy might feel absolutely nothing. So they keep walking on it, putting pressure on that damaged area, unknowingly compounding the injury. And what starts as a tiny little defect can turn into a deep, chronic, necrotic wound that might even go down to the bone.
Wow. Okay, and the third threat.
The third is the systemic metabolic problem itself. High glucose actually impairs how well immune cells work. Leukocytes, the white blood cells needed to kill bacteria and clean up debris, they become sluggish, inefficient. So this creates an environment that's just ripe for secondary infections. And when you combine that with the poor circulation and the ongoing unnoticed trauma, well, that's how you end up with those notorious persistent diabetic foot ulcers. It's really a catastrophic combination of three different systemic failures all hitting at once.
That structural framework you mentioned earlier, the collagen scaffold that needs to be built, it really depends on having the right materials available, doesn't it? Which brings us straight to nutritional status. You can't build a strong scar without good quality bricks and mortar, so to speak.
Absolutely. The impact of diet on healing is huge.
Yeah.
And two specific deficiencies really stand out in the sources as critical problems. General protein deficiency, and maybe more surprisingly for some people, vitamin C deficiency.
Vitamin C, okay, why is that one so critical? We tend to associate it with scurvy, but I guess that disease is essentially the ultimate failure of this exact healing mechanism, right?
Exactly right. Scurvy is the ultimate failure. Vitamin C, or ascorbic acid, acts as a crucial cofactor. Think of it like a helper molecule for certain enzymes, specifically prolyl hydroxylase and lysyl hydroxylase. These enzymes are absolutely essential for maturing collagen. See, collagen starts off as these long, sort of loose protein chains. To get its strength, its characteristic triple helix structure, these chains need to be chemically modified through a process called hydroxylation. It happens to specific amino acids, proline and lysine.
Okay.
And without vitamin C, that hydroxylation step just can't happen properly. So the body ends up producing defective collagen. It's poorly cross-linked, it can't assemble into strong fibers. The resulting scar tissue is incredibly fragile, weak, and it's prone to just breaking open again under minimal stress. That's precisely why scurvy symptoms include things like bleeding gums or old wounds suddenly reopening. It's literally the structural failure of the body's connective tissue because it can't stabilize the collagen properly.
Right. Moving on from deficiency to deliberate intervention, let's talk about a class of drugs that are often medically necessary but come with a known and sometimes difficult trade-off for healing. Glucocorticoids or steroids?
Yes, glucocorticoids. They're incredibly effective anti-inflammatory drugs, vital for treating everything from asthma to autoimmune diseases. But yeah, they definitely complicate wound healing. When administered, they tend to result in a scar that's noticeably weaker.
Why is that? If they're just reducing inflammation, why do they actively weaken the scar itself?
The mechanism is actually quite specific down at the molecular level. Steroids exert this negative effect mainly by inhibiting the production of a really key signaling molecule, a cytokine called TGF-E, that's transforming growth factor beta.
TGF-beta, I've heard of that.
It's incredibly important. You could argue it's the single most important, kind of the master cytokine, when it comes to stimulating fibroblasts, the cells that build connective tissue, and promoting the synthesis of collagen and fibronectin. It's basically the molecular commander telling the body to build scar tissue.
Okay.
So by blocking or dampening that TGF signal, steroids reduce the fibroblast response. That means less collagen gets deposited, the extracellular matrix is weaker, and therefore the final scar is structurally compromised. It just doesn't have the same tensile strength.
So you have this molecule, TGF-B, that's essential for a strong heal, but if you have too much of it, that's bad too, leading to fibrosis. That sounds like a real tightrope walk.
It is. It's the ultimate double-edged sword in repair. And this actually leads to a fascinating clinical point. Sometimes deliberately reducing fibrosis with steroids is exactly what you want to do.
Really? When would that be?
Well, the sources mentions specific situations like certain infections of the cornea, the clear part of the eye. Doctors might prescribe steroids alongside antibiotics. The specific goal there is to prevent excessive scarring in the cornea. Because if the normally transparent cornea scars over, it becomes opaque, and that causes blindness.
Ah, makes sense.
So in that very specific case, the risk of having a slightly weaker scar is considered less important than the need to preserve vision by keeping the cornea clear.
Okay, so we've talked about how systemic issues affect the quality of the building materials, the collagen, the energy supply, immune health. But even with the best materials, the project can fail if the actual construction site is unstable. Let's drill down now to the physical forces and conditions right there at the wound itself, starting with mechanical stress. I imagine if you ask surgeons what worries them most after an operation, it's often the fear that the tissue they just closed won't hold together. Things like pressure, tension, twisting forces, they can physically stop healing, right? And sometimes cause the wound to literally pull apart.
Yes, that's a major concern. That catastrophic failure is called dehiscence. It means the wound edge is just separate, like a zipper coming undone. And it's not random. It's often predictable based on simple biomechanics. You see, the tensile strength of a freshly closed wound is initially very, very low, sometimes less than 10% of the strength of undamaged skin. That fragile, newly formed granulation tissue just cannot cope with excessive force pulling on it.
Right.
Clinically, you see it more often when those systemic factors we discussed have already weakened the tissue, like in obese patients, where there's constant shear stress on abdominal wounds, or in malnourished patients who make that weak vitamin C deficient collagen.
Uh-huh.
But even simple sudden actions can trigger it. A really forceful cough, or a sudden bout of severe vomiting, or even just trying to lift something heavy too soon after abdominal surgery. These things dramatically increase intra-abdominal pressure. That puts immense mechanical stress right on the suture line, and pop, it can just give way.
Okay, so if mechanical instability is like the ground shaking under the construction site, then core perfusion is like a roadblock stopping the supply trucks, right? Healing uses a ton of energy, and if you can't get oxygen and nutrients delivered, the whole thing grinds to a halt.
Exactly. Poor perfusion, inadequate blood flow is absolutely fundamental to poor healing. It can happen because blood is blocked getting in, which you see in arterial problems like atherosclerosis or peripheral vascular disease. Or it can happen because blood is blocked getting out, which is more about venous issues like obstructed drainage and severe varicose veins.
And the main problem is lack of oxygen.
That's the critical consequence, yes. Lack of oxygen. Without enough O2, cells like fibroblasts and the endothelial cells lining new blood vessels have to rely on very inefficient anaerobic metabolism. They produce far less ATP, which is the cell's energy money, so they can't divide properly, they can't make collagen efficiently. And crucially, immune cells like macrophages and neutrophils need a lot of oxygen to generate those reactive oxygen species they use to kill bacteria effectively.
So a poorly perfused wound isn't just slow to build, it's also much more vulnerable to the infections we talked about earlier.
And once that site is maybe open, or even if it's closed but there's something trapped inside, there's the challenge of foreign bodies. We might think of splinters of glass or metal, but even things like suture material or a tiny fragment of bone can act as a foreign body, right? What exactly is the mechanism there? I mean, if the material is inert, say a little piece of smooth plastic, why can't the body just kind of build a wall around it and get on with healing the rest? Why does it keep restarting the inflammation? This is a classic example of something called the frustrated phagocyte response. Macrophages, those immune cells, are programmed to basically eat and digest foreign stuff. But if they encounter something that's too big to engulf, or too hard, or just chemically indestructible, they get frustrated. They keep trying to attack it or wall it off, and in the process, they just keep releasing a flood of inflammatory signals, cytokines, and enzymes designed to break things down.
I see.
Because the foreign object stays there, it acts like a permanent irritant, a constant trigger. So every time the body tries to shift gear into the proliferative building phase, the presence of this thing triggers more inflammatory signals, forcing the tissue right back into the defense and cleanup mode. It essentially locks the area in a state of chronic, low-level inflammation, and that permanently stops the transition to proper healing and remodeling.
Wow, that's fascinating. The body's own cleanup crew becomes the very thing stalling the repair. Okay, finally, in this section, we need to touch on the fact that not all tissues are created equal when it comes to healing. The potential is fundamentally set by the type of tissue and also where it is in the body.
Exactly. This brings us back to that core question of regeneration versus scarring. But at the really basic cellular level, we generally categorize tissues based on their built-in ability to divide. We call it their intrinsic proliferative capacity. So first you have labile tissues. These are cells that are dividing continuously throughout life. Think of the surface epithelia of your skin, or the lining of your gut, or blood cells in your bone marrow. As long as the underlying structure, the basement membrane, and the stem cells are okay, these tissues can generally regenerate completely. Then you have stable tissues. These include cells in organs like the liver, kidneys, or even bone. Normally, these cells are quiet, just doing their job, resting in what's called the G0 phase of the cell cycle. But if they get injured, they can be triggered to re-enter the cycle and start dividing quite rapidly. The liver is the classic example. It has an amazing capacity to regenerate after injury.
But the real challenge, and maybe the most, well, sobering part of this, lies with the tissues that are most critical for our immediate function, like brain and heart.
That's right, the permanent tissues. This group includes most of the neurons in your brain and spinal cord, and also your cardiac muscle cells. These cells are terminally differentiated, they've reached their final form, and have basically zero ability to divide significantly after birth. So any injury to heart muscle, like after a heart attack, or injury to the brain, it results in a permanent loss of that functional tissue. It inevitably gets replaced entirely by scar tissue, fibrous tissue that can't conduct nerve impulses or contract like muscle. Function is just lost.
And where the injury happens matters too. You mentioned location.
Yes, the anatomical location can change the style of repair. Think about inflammation occurring in big tissue spaces like the pleural cavity around the lungs, the peritoneal cavity in the abdomen, or the synovial cavity inside a joint. Inflammation there often generates a lot of fluid buildup, these protein-rich fluids called exudates.
Right, like fluid on the knee.
Exactly. Now, if the amount of exudate is small, the body might be able to break it down with enzymes and just reabsorb it. That leads to resolution, back to normal. But if you get large amounts of this fluid accumulating and it just sits there, the body basically sees it as a big empty defect that needs filling. So granulation tissue, that early repair tissue, starts to grow into the stagnant fluid, replacing the liquid with solid, fibrous connective tissue.
Ah.
That process is called organization. It's the body essentially filling a void with scar. And often this leads to problems like fibrous adhesions, bands of scar tissue in the abdomen that can kink the bowel, or scarring that restricts how much a joint can move.
Okay, so now let's connect all these dots, the systemic problems, the local issues, the persistent inflammation, to what we actually see happen when healing goes badly wrong. This brings us to the really difficult scenarios of deficient scarring and chronic wounds.
Chronic wounds are really defined by their failure. They fail to move through those normal, orderly stages of healing in a timely way. And almost always, they're the result of multiple factors, both local and systemic, kind of conspiring against the body. Usually it involves poor blood flow and often an uncontrolled underlying disease like diabetes.
Maybe we can use the main types of chronic ulcers as examples. They seem to illustrate how these factors combine. Let's start with venous leg ulcers. These usually happen because of long-term problems with the veins in the leg, right? Like severe varicose veins.
Exactly. They're caused by chronic venous hypertension. Basically, the blood struggles to get back up the leg towards the heart, so it pools in the lower leg veins. This causes congestion. The mechanism is that constant high pressure in the veins forces fluid to leak out into the surrounding tissues, causing edema or swelling. This pooling creates chronic inflammation, and crucially, it makes it hard for fresh oxygenated blood to get in, even if the arteries are working fine. A classic sign you often see is brownish staining of the skin. That's from hemosiderin iron pigment left behind when red blood cells break down in the congested area. These wounds heal incredibly slowly because the tissue is constantly swollen, inflamed, and starved of oxygen, which stops the cells from working properly.
Okay, then in contrast, you have arterial ulcers. They sound like the opposite problem.
They are, essentially. Arterial ulcers come directly from atherosclerosis, the hardening and narrowing of the arteries that supply blood to the limb. So the failure here is pure, intense ischemia, a literal starvation of oxygen and nutrients getting to the tissues. This leads to the skin becoming thin, pale, perhaps shiny, and eventually areas of sharp, well-defined tissue death or necrosis. And because the nerve endings are also starved of oxygen, these ulcers are often intensely painful, unlike the venous ulcers, which can sometimes be less painful due to the congestion.
And then the diabetic ulcer is where it all seems to come together.
Yes, the diabetic ulcer is that classic multifactorial nightmare scenario we discussed. You get the ischemia from the damaged small blood vessels, you get the blindness to injury from the neuropathy, and you get the high risk of secondary infection because the immune system isn't working well. It's this perfect storm leading to deep tissue destruction, usually on the feet, and a profound failure to heal. Sadly, it's a major reason for lower limb amputations.
And just quickly, pressure sores, bed sores, they illustrate a purely mechanical cause of ischemia, right? Yeah, these happen from prolonged, unrelieved pressure, usually where tissue gets squeezed between a bone like the hip or the heel or the tailbone and an external surface like a bed or chair. It happens in patients who can't move themselves easily.
That constant pressure physically clamps down on the tiny capillaries, completely cutting off the local blood supply. It causes localized ischemia and cell death, necrosis, and then that dead tissue acts as a constant source of irritation, keeping the wound inflamed and preventing it from closing.
Okay, shifting gears from wounds that don't heal enough, what about when the body goes overboard? Excessive scarring, where too much connective tissue, mostly collagen, gets laid down.
Right, this is the other side of the coin, and it's really important to distinguish between two main types here. First, there's the hypertrophic scar. This is a scar that's raised, often red, feels quite firm. It's caused by too much collagen building up, and it often grows quite quickly. You find lots of specialized fibroblasts called myofibroblasts in there. But the key thing about a hypertrophic scar is that it stays within the boundaries of the original injury. And importantly, it tends to gradually flatten and soften or regress over several months or even years. Think of it like maybe a really thick layer of paint that stays within the lines.
Okay, within the lines and might get better over time. And then there's the keloid. What's the difference?
The keloid is fundamentally different. This is scar tissue that grows aggressively, extending beyond the original wound boundaries. It actively invades the surrounding normal skin. And keloids almost never regress on their own. They often continue to grow slowly over time.
So the main thing with keloids is they grow outside the original wound.
That's the defining characteristic, yes. It strongly suggests there's an individual predisposition, likely genetic. Our sources note it's much more common in people with darker skin, particularly those of African American descent. Microscopically, keloids look different too. They have these really thick, disorganized bundles of collagen that look glassy or hyalinized. It's far more collagen than is needed for structural support.
There's also something called exuberant granulation or proud flesh. That sounds almost positive, like the body is healing really well, but it's actually a problem.
It is, yeah. It's actually a mechanical blockage happening during the proliferation stage. Granulation tissue is that pink, highly vascular tissue that fills the wound bed early on. Sometimes it just grows too much, forming a raised mound that protrudes above the level of the surrounding skin surface. This proud flesh physically gets in the way of the final step, which is reepithelialization, where the skin cells migrate across the wound bed to cover it up. If the skin cells can't climb over this protruding mound, the wound just stays open.
Okay.
So often, to allow the skin to finally close over, this exuberant tissue needs to be reduced or removed, maybe with chemical cautery or minor surgery.
And finally, related to excessive deposition, but also involving those contracting cells, contractures.
Right. Contractures are basically an exaggeration of a normal healthful process. Myofibroblasts, those specialized fibroblasts that can contract like smooth muscle cells, normally help pull the edges of a large wound closer together, making the area that needs to heal smaller. But when this contraction process becomes excessive or disorganized, it can lead to severe deformities. This is especially problematic when the scar crosses a joint. Think of the palm of the hand, the sole of the foot, or across the front of the chest or elbow after a severe burn. The scar tissue tightens and tightens, severely restricting movement and function. It's like the body prioritizes closing the hole above all else, even if it means sacrificing mobility. Hashtag updates, research findings, and advancements. So, many of the problems we've been discussing, these chronic wounds that won't heal, but also major diseases like liver cirrhosis, chronic kidney disease, idiopathic pulmonary fibrosis where organs fail, they often come down to one central issue: uncontrolled, excessive deposition of collagen. Fibrosis. Fibrosis in major organs is now recognized as a huge cause of dysfunction and death worldwide. Because the impact is so devastating and often irreversible, there's enormous interest right now, a huge research push into developing targeted antifibrotic drugs that can specifically modulate that repair response, basically tell the body, okay, that's enough scaffold, stop building now.
And I guess that brings us right back to that master regulator we talked about, TGF-α. If you want to stop fibrosis, you probably have to target the signal that drives it.
That's exactly where a lot of the focus is. Since TGF-β is the key driver, it tells fibroblasts to divide and make much more collagen. A major strategy is trying to inhibit its signaling pathway. Researchers are looking at things like small molecule drugs that could block the TGF-β receptor on the fibroblast, stopping the build scar message from getting through. The big challenge, though, is that TGF does lots of other important things in the body, regulating cell growth and immune function. So finding a drug that blocks the pathological fibrosis without causing serious side effects elsewhere, well, that's proving really tricky.
Okay, let's shift from the signaling to the actual scar matrix itself. The final outcome isn't just about how much material gets laid down, but also how it's shaped and refined over time, right? You mentioned a remodeling phase. It sounds like a constant push and pull between building and demolition.
That's a great way to think about it. That remodeling phase is absolutely critical for getting a scar that's functional, not just space filling. The final structure is determined by this ongoing balance between making new extracellular matrix ECM components like collagen and breaking down the old or disorganized stuff. And the breakdown crew is managed by this really interesting family of enzymes. They're zinc-dependent and called matrix metalloproteinases, or MMPs.
MMPs. Yep.
They are the body's sort of precision demolition team. Their job is to selectively chew up old, poorly arranged collagen fibers. This allows fibroblasts to then replace them with new, stronger collagen fibers that are better aligned along lines of stress.
hmm
This is absolutely essential for refining the scar and maximizing its final tensile strength over months or even years.
And presumably these MMPs, this demolition crew, they need to be tightly controlled too. You don't want them running rampant.
Exactly right. They are very tightly regulated, primarily by another set of proteins called tissue inhibitors of metalloproteinase, or TIMPs. So the balance between MMP activity breakdown and TIMP activity, inhibition of breakdown, is crucial. And a lot of new research is looking at ways to manipulate this MMP to TIMP ratio therapeutically. For example, in some chronic wounds, the problem might be too much MMP activity, constantly breaking down the fragile new matrix as fast as it's made. In that case, maybe boosting TIMP activity could help stabilize the new scar.
I see.
Conversely, if you have a really dense problematic scar like a keloid, maybe you'd want to find a way to carefully increase local MMP activity to help break down some of that excessive collagen and encourage better remodeling. It's all about trying to fine-tune that balance between construction and deconstruction.
And finally, let's bring this back to the immune system, specifically those macrophages. You mentioned earlier how they shift roles. That ability of one cell type to go from being basically an agent of destruction to a master of construction, that seems incredibly important for the future of healing, doesn't it?
It's absolutely central. Macrophages really are the bridge between the initial injury response and the subsequent repair. First, you have the inflammatory M1 macrophages. They're triggered by infection, by dead cells, by debris. They dominate that early acute phase, killing pathogens and cleaning up the mess. But the critical turning point for successful healing is when this M1 population starts to get replaced by, or switches its function to become, the alternatively activated M2 macrophages.
And the M2s are the good guys in terms of repair.
They are the constructive force, yes. They are pro-resolving, meaning they help shut down inflammation. They're anti-inflammatory themselves, and they're essential for driving the proliferative phase. They finish clearing up the debris, but crucially, they release a whole different set of signals, including essential growth factors, yes, even TGF, but in a more controlled way, and they actively stimulate fibroblasts to divide and synthesize that new connective tissue matrix. So a lot of cutting-edge research is focused intensely on finding ways, maybe pharmacologically, maybe by manipulating cell metabolism to speed up or better control that switch from the M1 state to the M2 state.
What kind of approaches are being explored to actually control that switch?
Well, researchers are looking at various things. Specialized lipid molecules, called resolvins and protectins, that naturally promote the resolution of inflammation, seem to push macrophages towards the M2 phenotype. There's also work on small molecule drugs that might directly target signaling pathways inside the macrophage to kind of re-educate them. The idea is, if we could reliably signal the local environment to quickly dial down that destructive M1 activity and dial up the constructive M2 activity, we could potentially bypass a lot of the problems associated with chronic inflammation. It could significantly accelerate functional repair in all sorts of injuries, from diabetic ulcers right through to recovery after a heart attack. Hashtag tag to inclusion.
So if we just step back and look at the big picture here, I think the main takeaway is that tissue repair isn't some kind of guaranteed automatic process. It's actually a pretty fragile, really sensitive system that's constantly being influenced by, well, a whole host of factors. We've seen how things ranging from the really big picture, your overall health, whether you have diabetes, what you eat, right down to the microscopic level, the exact balance of local signals like TGFA, the state of the matrix itself, they all intersect. Even simple things like not getting enough vitamin C or complex diseases, they all converge right down at the cellular level, messing with fundamental processes like making collagen or getting cells to divide properly.
And so successful healing really seems to hinge on maybe three core principles. First, minimizing the initial damage, preserving as much original tissue as possible, and controlling those mechanical stresses. Second, ensuring an adequate supply line, good blood flow, bringing oxygen and nutrients. And third, maybe most critically, achieving effective and timely control over that initial inflammatory response. The ongoing battle against chronic wounds, which affect millions of people, and the fight against organ failure caused by fibrosis. It really all comes down to our ability to understand and control these influencing factors to make sure the body successfully transitions into and completes those constructive restorative phases of repair.
Yeah, that switch, that moment the body decides to stop fighting and really commit to rebuilding, that seems to be the absolute key to regenerative success. Which leads to a final thought for you, our listener. If we could get really good at precisely controlling that switch, maybe specifically managing the transition from the destructive M1 macrophage to the constructive M2 type, what does that mean for the future? What could surgery and regenerative medicine look like? Could we maybe one day custom engineer scars, make them perfectly strong but maybe cosmetically invisible or ensure they don't impede function at all? Could we even perhaps eliminate harmful scarring entirely in some situations? That's the challenge and maybe the promise that lies ahead, all built on understanding and manipulating these incredibly intricate biological levers.